The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day. I am Dr. Kurt Roland Alfonso Asperas, continuing our discussion for anatomy and histology. And particularly for my part, I will be discussing concepts about the abdomen, particularly that of the kidneys, ureters, and bladder. The kidneys are said to be paired organs located at the retroperitoneum, with the most superior portion noted to be at the level of T12 and the most inferior part at the level of L3. Now, we have structures that what we call the renal hilum, and it is composed, or there are 3 structures and enters and that leaves the renal hilum, namely your renal vein, your renal artery, and your renal pelvis. At this point, I'd like you to memorize the spatial relationship of these 3 structures. The renal vein is the most anterior portion. On its back would be the renal artery, and the most posterior structure is the renal pelvis. This is particularly important when we do our dissections if we want to identify either structures, meaning if we were able to see the artery, we are more or less sure that the vein can be found anterior to it. Likewise, if we're looking for the renal pelvis, it is behind your renal artery. So it is also worth noting that your renal hilum can be leveled at L2. Okay, this is an important landmark because if you want to locate the vital structures easier or from the get-go, we would like to level our incision such that we could expose at the level of L2. So how would you remember that? How many kidneys do you have? 2. So the kidneys or the renal hilum can be leveled at L2. The kidneys is being surrounded by a true fibrous capsule at this part. Meron tayong true capsule here. Yan. Outside of that capsule is what we call the perirenal fat. Its purpose being a cushion to protect the kidneys. So it is this part or the fat layer in the diagram. More or outside of your perirenal fat is the Gerotas fascia, also known as your renal fascia. It is a thick band that envelopes almost the entire kidney. Why? It is open inferiorly, or ibig sabihin, your Gerotas fascia only covers these portions. Bukas siya sa baba. So what would be its complication? When we have cases of renal hematoma or bleeding from the kidneys, the bleeding is likely confined inside the Gerotas fascia. Diba? That's why it's a good tamponade. Actually, pag nagbe-bleed ang kidney natin, it is more or less easily contained by your renal fascia. But if the bleeding is very severe or bad enough, where would you expect the blood to go? It will not extravasate outside, but rather the bleeding will seep downwards, and when you do your ultrasound, the CT scan, it would tell you that there is bleeding in the pelvis but not around the kidneys. So why did that happen? Because you know anatomically that the kidneys are being surrounded by your Gerotas, and the Gerotas is open inferiorly. Outside of the Gerotas, we have again another fat layer that we call as pararenal or paranephric fat. So how do I remember or define and differentiate which is pararenal, which is perirenal? Our buzzword there is perirenal fat. Renal fat sounds like in or inside. So the perirenal fat is inside of your gyrotous fascia, and the other one is the other one. Outside of the gyrotous would be your pararenal fat. Okay? Now let's proceed with the spatial relationships of the kidney to other vital structures. As said, the kidneys are retroperitoneal organs. Meron siyang sariling cavity sa flank, sa likod. So if you were able to assist in urological surgery na sa likod sila naghiwa, I tell my interns na dapat wala tayong makitang bituka. Because anatomically, you know that the intestines are completely separate or in front of the retroperitoneal organs, and it's being surrounded or enveloped by a true covering the peritoneum. Okay, so if you are well good enough with your dissection, wala ka dapat makikitang bituka if your surgery is just focused on the kidneys. So in this picture, this is anatomical or accurate representation of the lie of your kidney. Okay, what are your first observations? The right kidney is set to be slightly lower than your left kidney. Why is that so? Because the right kidney is being pushed down by the liver. Kung sa right side, ang nakadikit sa kanya ay si liver, on the left side naman, andito si spleen. Also, on the right side, ang mga structures that are densely are in close relationship with your kidney would be here at this area. A curving tubular structure that we call the duodenum. So the duodenum is here, the D1 or the first portion of the duodenum, and the curving or the curvature part of the duodenum, D2, and then lastly, D3. So the area of the duodenum very close to your right kidney would be D2. Okay, it follows the duodenum is here, therefore the stomach is here. And the stomach is now in close relationship with your left kidney. What is near D2? Okay, the periampullary area of your pancreas. So the pancreas would be here. So having said that, it can now be said that the tail of the pancreas is incomplete or is in close relationship with that of your left kidney. Following the duodenum, of course, magje-jejunum yan dito. Okay, magje-jejunal part. Eventually leading to your ileum, to your cecum, and to your ascending colon or your large intestine na. It will touch the liver, hepatic flexure. That's why the right colic flexure or the right hepatic flexure is in close relationship naman now with your right side. And on the left side, bababa naman siya, splenic flexure to your descending colon. That's why when we are approaching the kidneys intra-abdominally or ibig sabihin, ang hiwa namin sa harap, and we want to see the kidneys, what do? We release the colon from its attachment to the abdominal wall. We flip it inwards. Pag na-flip na siya like a page of the book, only then can we see the kidneys. Kung sa harap kami dadaan. Alright? So as a recap, on the right kidney, it is in close proximity with your adrenal gland, the liver, the second part of the duodenum, and the right colonic flexure. On the left side naman, same, adrenal gland, this time the spleen, the tail of the pancreas, the stomach, the left colic flexure, and the jejunum. Posteriorly, sa right and sa left, halos pareho lang sila. Okay? Probably may 12 thread lang on the left side because the left kidney is slightly higher than the right kidney, but otherwise everything else is the same. And what would you notice? From the posterior, the kidneys are walang vital structures closely adherent or adjacent to them. Therefore, in surgery, it is safer for us urologists to approach the kidneys from the back or start our mobilizations from the back Because the chances are na may ma-injure kaming vital structure from behind is slightly less or lower than approaching it from the front. Kanina ba tayo retroperitoneum ng retroperitoneum? What does that really mean? Okay? So, retroperitoneum inside of the peritoneum. This is the peritoneal cavity. Contained inside would be your GIT mostly. Okay? So, meron tayong sariling cavity and out at the back of it, doon na natin makikita yung structures like your kidney, your inferior vena cava, and that of your abdominal aorta. So now I ask you, am I looking from the foot or from the head of the patient? Okay. The answer there, or is it the right, or is it the left kidney? How would you know? I tell you, this is the right kidney. How was I able to deduce that? Here, look at the relationship of the inferior vena cava with that of your aorta. Please take note that on the right, there you would find the inferior vena cava. On the left would be the abdominal aorta. So what would be its implication or paano siyang maaalala? We have surgeries, for example, nephrectomy or an open donor right nephrectomy. So when we do nephrectomies, we incise here or we cut here. We cut through this section, open the muscle layers to see the right kidney. And our dissection will proceed in this manner. When we do our dissection, when we see the kidneys, we are worried that the first major structure that we will encounter would be the IVC. So, yung first na makikita namin. In fact, during our dissection, hindi namin nakikita ang abdominal aorta. Okay? Going back or building up on our previous topics, this is the kidney surrounded by your perirenal fat inside the gerotas. Outside the gerota would be your pararenal fat, and then it is being covered by a muscle layer or muscular layer, your external oblique, internal oblique, and your transversus abdominis. Alright? At the back or the most superior portion, the big muscle groups that you would encounter would be the quadratus lumborum, and the most important one being the psoas major muscle here. In Europe, we use the psoas muscle as an anatomic landmark because, as said kanina, your kidneys is nested right on top of your psoas. Sabi natin, di ba, its angulation, its orientation actually follows that of the psoas. The psoas starts laterally and goes medially almost like a triangle. Okay, so having said that relationship, the kidneys is also expected to be deflected in such angle. So with the inferior portion slightly being more lateral and the most superior portion being more medial rather. Cross-sectionally, because the psoas is here, okay, the kidney doesn't lie like in a perfect perpendicular angle. It's more of angulated to correspond to the angle also, or the bulge. Because the psoas is like a tube, it is expected to lie just on top or following the curvature of your psoas major. Okay? Now we will be tracing the blood supply of the kidneys. So at this point, I'd like to take note, or I'd like you to remember the structures in the kidneys that we have this that I think is known to you already at this point. We have what we call the renal papilla. At this level, papilla is the portion of the kidney kung saan nakikita natin yung mga loop of Henle, sounds familiar, where the filtration actually happens. And the byproduct of that filtration, as we all know, is urine, and it drains, so that urine drains to a calyx. So pag calyx yan, part na yan of the collecting system, or yan na yung nanongolekta ng mga byproduct, which is the wee-wee. Okay? So, why is that important? Why are those landmarks important? Because doon nagpapalit-palit at their levels yung pangalan of the renal artery. The kidneys, for majority of people, is being supplied by a single artery on the right and a single artery on the left. But there are also people that would have second, two, third, or fourth renal arteries. That doesn't mean they have pathologies, but it's more of an anatomic variation. But I think for anatomy, this is an exam, commonly or the most common variation is for person to have a single renal artery. That renal artery subdivides into segmental arteries, okay? And then further subdivides as it crosses the calyx to become your lobar, again subdividing into interlobar here, interlobar. You expect it to begin at the junction of your calyx and your papilla, and eventually it arches over or arcs over your renal papilla, hence the name arcuate. It's an arcing structure at the junction or at the angle of your renal papilla. And then it subdivides further to what we know or what we call interlobular arteries, eventually leading to afferent glomerular arterioles. Sounds familiar? Yes. So at this level, I'd like you to appreciate the subdivisions of the renal artery to a histological level, how it reaches the nephrons, the functional unit of the kidneys for actual filtration. So let's follow the blood again on the next slide. So let's follow the course of oxygen-rich, nutrient-rich, unfiltered blood that flows from the renal artery, okay, going to the segmental arteries, and then now to the interlobal artery. As it arches over the renal papilla, it's now called your arcuate artery, and that same artery will further subdivide into interlobular and to finally an afferent arteriole that, as you would remember, is part of the whole glomerular complex. It is the actual unit involved in the filtration of the blood via your glomerulus. And at this part, diba, magkakaroon tayo ng series of resorption, secretion to come out with the final product, which is in the urine that will be drained into the renal calyces for final disposal via the pelvis down to the ureter. So the filtered blood would go to the efferent arteriole to be brought back to the venous circulation via peritubular capillaries and vasa recta. And it will now drain to the interlobular, arcuate, interlobal, and finally the renal vein back to the IVC. If you would notice, the names of the vein corresponds to their name in the arteries. Pinapalitan lang na vein na an artery based on its anatomic level, kung nasa arc ba siya ng may papilla, or is it in the interlobular area or interlobar area. So at this point, we'd like you to appreciate, diba, from a gross structure all the way down to the microscopic structure. Napakaganda ng organization ng vasculature of our kidneys. Needless to say, the major venous drainage of the kidneys is to the inferior vena cava that is found more anterior and on the right side of the patient. Okay, posteriorly again, sorry I could not repeat this enough. Posteriorly would be the renal artery, and the most posterior portion would be your renal pelvis. So some points about the vasculature of the kidney. The right renal artery is longer and it passes posteriorly. Look at the relationship here. It passes posteriorly to the IVC. Whereas the left renal artery courses posterior to that of the renal vein. Okay? The left renal vein is longer because it passes over your superior mesenteric artery and as well as your abdominal aorta. So what are the implications, or how would you remember it better? Are you familiar with donor nephrectomy, or ibig sabihin donation ng kidney? In med school, you have been told that the preferred side to be donated anatomically would be the left side. Why is that so? Does it because may special sa kidney mismo nung left side? Wala. Pareho lang si right and si left. What's special about the left kidney are the length of its vessels. Okay? The left renal vein is longer because it has to cross on top pa of your aorta. The aorta is approximately around 2 to 3 centimeters, and that crossing affords us more length to get the left renal vein, and longer vessels would entail a partly easier anastomosis of the graft kidney to the recipient. So, mas mahaba yung vessels, mas madaling ikabit. Kaya, mas madali daw or mas favorable for the transplant side if we will give them the left kidney. Okay, that's not a rule of that's not a golden rule. But if the choice will be based on anatomy alone, the left kidney is preferred because it has longer vessels. The left renal vein is longer kasi may extra length pa siyang na-add because it has to cross pa on top of the abdominal aorta. Okay? So we're done with the kidneys. We're now proceeding with the suprarenal gland, also known as your adrenal gland. So adrenal gland are small structures normally weighing around 4 to 5 grams, and as discussed in IM and in physiology, it has 3 zones, namely your zona glomerulosa, responsible for the production of aldosterone, fasciculata for cortisol, and the reticularis for your androgens. So again, they are paired organs found lying on top of your kidney. Embryologically, the adrenal gland is separate or hindi siya same origin with that of your kidney. So, embryologically, it's implication that there are cases na hindi nag-develop or yung kidney or totally absent yung kidney, but you are still to expect that on that side, meron pa siyang adrenal gland. So, kahit magkapangalan sila or they share the same last name, hindi sila related to each other. Completely separate ang kanilang development. As for the supply of your adrenal glands, or it is being supplied by suprarenal arteries or your adrenal arteries that are branched and also branches from the superior and inferior phrenic, middle and abdominal aorta, and inferiorly from the renal artery. So, ang takeaway natin dito, the adrenal glands is very well perfused. Okay? Meron siyang sarili niyang arteries in the form of your suprarenal arteries, but even if matransect mo yan during surgery, it will still be perfused by its other blood supply or source. Also, ang implication din yan when you do adrenal surgeries, diba? In theory, if you were able to ligate the main source, like in the kidney, naligate mo na yung renal artery, it follows na hindi ka na dapat duduguin. Okay, but for adrenal surgeries, you have to be in mind na multiple almost ang blood supply of our adrenal. Likewise, the venous drainage of your adrenal, on the right side, it drains directly to the IVC. On the left side, it drains first into the left adrenal vein, to the renal vein, and then finally to the IVC. Kaya nila to favorite sa exam. Because different ang drainage ng left sa right. Sa right, okay, almost always direct ang drainage niya to the IVC. Adrenal gland draining directly to the IVC. Whereas yung left, dadaan muna siya sa renal vein to the IVC. Sounds familiar, di ba? Meron kayong naalalang vein na ganyan din yung course. Okay? The gonadal vein. Ang gonadal vein, ganon din siya. Ang gonadal vein is here. On the right side, it drains directly to the IVC. On the left side, it also drains to the renal vein first before it drains finally to the IVC. So, tandaan niyo na adrenal and gonadal. Okay, those are concepts na high-yield in the exam because mayroong difference ang right and left. Okay, done with kidneys, done briefly with the adrenal. Let's move on to the next organ, which are your ureters. Continuing our discussion, we will now be talking about the ureter. Paired tubular organs na ang main function niya is to conduct the urine from the kidneys all the way down to the urinary bladder. So the ureters can be divided into three portions: your abdominal, your pelvic, your intravesical or intramural portion. Or sometimes you call them the proximal, the middle, and the distal ureter. So for this portion, the relationships that I'd like you to remember, for the blood supply and the proximal part, it is being supplied by branches from the aorta. Whereas from the more distal part, it's being now supplied by the vessels coming from your iliac vessels. And look at the relationship. Proximally, okay, the blood supply comes from the medial going more lateral, whereas when you reach the more distal portions, the blood supply comes laterally, inserting to the medial aspect or going medial naman siya. So what is its implication? Okay, when we do our surgeries, para maalala niya din siya. If we have to do surgeries in the abdominal part of the ureter, we open the ureter on its lateral aspect because we know for a fact na yun yung least vascular portion. Hindi tayo duduguin doon. If we open the lateral portion, because the blood supply of the ureter is going medial naman. Likewise, kung distal yung operation natin, okay, we want to preserve as much vascularity, therefore we will open the more medial side. Okay? But ang mas sikat in terms of exam of anatomy is what we call the ureteral constriction, or may mga narrowing. Constriction siya, and it's not a stricture. Okay, stricture is pathologic, constriction is expected, or kumbaga ganyan talaga structured yung ating ureters rather. Yung ureters, yung collecting system of our kidney, alam niyo yung imbudo. Okay, it follows the same principle. If you want to transfer liquids to a smaller container, ano yung ginagamit natin? We use a funnel. We use an embudo. So, ganun din yung principle in the kidneys. So, having said that, it follows that the more superior part is wider than the more inferior part. So, amongst the three constrictions, which are namely UPJ, okay, where your ureter crosses in the iliac vessels, and where it inserts to the bladder, or what we call the UVJ, ang pinakamalisikip or pinaka-constricted dyan would be the UVJ. So clinically, it is always discussed, especially for the exam, in the context of a ureteral stone or ureterolithiasis. It would ask you kung saan likely malalodge ang stones in the kidney. So you would answer probably UPJ, iliac crossing, or higher chances sa pinakamaliit na portion where the ureter pierces the bladder wall. Okay? More about the relationships of the ureter. Posteriorly, the ureter is in close proximity with the gonadal artery and vein, and it's anterior to the common iliac and internal iliac. Look at this portion here. These are your common iliacs, and your ureter crosses on top. Okay, crosses on top of your common iliac vessels. This is very important in the surgical aspect if you want to locate the ureter. Okay, for the ureters, what we use, the psoas muscle and the iliac vessels. Those are more or less fixed structures. And ang maganda pa sa iliac vessels, nakakapayan. You would see it pulsating, or you would feel it pulsating. In the contrary, ang ureters kasi natin has a tendency to be mobile or moving. So, depending on the retraction, pwedeng nasasama sa retraction yung ureter, kaya mahirap siyang i-locate. So, to avoid that mistake, we identify the psoas and we palpate for the common iliac vessels because we know for a fact that the ureter can be found anterior to the common iliac vessels. And the ureter is below and behind the uterine blood vessels. The uterus can be found here in females. So again, what is its clinical implication para hindi nyo makalimutan? When you do your hysterectomies, yung mga tabiso, our OB-GYN friends are very worried that they might injure the ureter. Okay? Because of this relationship. As they are ligating the blood supply of the uterus, they run the risk also of masama or ma-injure ang ureters. That's why when they do their tabiso, if they can, kailangan i-dissect away nila yung ureters from the uterus because pwede nilang tamaan yun, especially the more distal or pelvic portion of the ureter. The last topic for this part of this lecture would be the lymphatic drainage of your kidneys. Okay, so here for the posterior drainage of the retroperitoneum includes external internal iliac lymph node draining to the more common iliac as it courses up to the para-aortic. Dito na magde-drain si posterior abdominal and ectopic kidneys and the ureters, the gonads, the uterus, and the uterine tubes. So basically, ito yung important sa atin. Your para-aortic lymph nodes. Okay? In the context of renal cancer, pag pina-CT scan nyo yung mga patients with renal cancer, the radiologist would put into their report that there are no enlarged para-aortic lymph nodes because we know for a fact that the drainage system of the kidneys is to your para-aortic lymph nodes. Doc, yung ureters, gets ko. Saka yung retroperitoneum, gets ko din na nasa para-aortic sila kasi malapit talaga. But why are the gonads there? Okay, if you remember ulit, in the right side, the right gonadal vein drains directly to the IVC. On the left side, it drains to the left renal vein. So that relationship closely approximates the lymphatic drainage as well. Okay, kaya kahit seemingly nasa baba ang gonads, ang drainage niya nasa taas pa din. Okay? And it goes to the lumbar lymphatic trunk to eventually drain to the cistern chyli, to the aortic hiatus, and to the rest of the lymphatic drainage that we all know. So, bakit ko ito siya minimension? Because when we do our nephrectomies also, we are prone to leaving the lumbar lymphatic trunk open. So, dyan minsan napapansin natin na may nagli-leak na lymph fluid, or kung talagang hindi control, pwede magkaroon ng fluid collection talaga if you were unable to get this portion correctly or identify this during surgery. Okay? So continuing the segment for the anatomy and histology of the KUB, we proceed now with the urinary bladder, or in Tagalog, pantog. Urinary bladder is said to be an ovoid-shaped pelvic organ when filled. In an adult, it could hold as much as 500 ml in full capacity. Okay? Para siyang ovoid shape, para siyang bola when filled. But when it's empty, it's actually tetrahedral in shape. So, ito yung shape niya. This is the anterior view, and this is a sagittal view. So, what's important here is we remember kung saan siya naka-attach or to which points they are anchored to. Because we don't want naman the bladder to be flopping pag wala siyang laman. It has to be fixed to a certain structure to allow passive drainage of urine para mas ma-facilitate na mag-expand siya as it fills up with urine. So how does it accomplish that? It is anchored to the superior aspect using or via your urachus. Does the urachus sound familiar? Okay, by embryology, the urachus is the communication of the allantois or allantois and the cloaca. And then upon birth, diba, it obliterates to become your urachus, aka / your median umbilical ligament. Do not confuse it with the medial umbilical ligament. Pag medial, yung dalawang labas. Okay, L standing for labas. The medial, yung dalawang labas, and we are the remnant naman of the what? Your umbilical arteries. So, median, in the middle, that's your previous urachus. Lateral, siya yung nasa labas. Those are your medial ligaments. Posterior inferiorly, especially for males, the bladder is anchored to the prostate. So we have discussed the prostate previously, right? Your bladder, okay, it forms like a funnel shape and it converges with the bladder neck. Natin yung tinatawag natin. It is the point of communication where the bladder transitions to become your urethra. So going back to my question, saan naka-attach ang ating bladder? Superiorly, it's connected all the way up to the navel via your urachus or your median umbilical ligament. Anteriorly, we have pubovesical ligament and your pubourethral ligament. For the exam purposes, siguro hindi ganun ka-pertinent ito, but be it known that the bladder is fixed anteriorly and superiorly. Okay? Which is kind of very physiologic also, di ba? Para pa nag-expand siya as the bladder gets heavy and heavy when you're in recumbent position, better yung magiging stretching of your surfaces. Alright. For the histology, madali lang po ang bladder. In fact, lagi siyang ginagamit na point of discussion when discussing about special histologic subtypes, di ba? As you all know, the urinary bladder is lined by your transitional epithelium. Other terms used, urothelium, because it's very particular or specific to your bladder, to your ureters, all the way up to the collecting system, yung mga calyx na yan. This histology brought up because of necessity. Because our KUB is a system that has to be able to accommodate the passage of urine, mapadami or mapakonti, may some form of expansion na dapat i-allow. And that's exactly what's accomplished by the histology of it being layered or pseudostratified. Therefore, when it stretches, look at this, it lengthens but not breaking the continuity of your epithelium. And at the same time, when it contracts, it can overlap the cells, diba? Ang galing. So just a part of your bladder again, if you would remember, here it is again, the median umbilical ligament. And your ureter courses posteriorly to the bladder. And it courses, di ba? If you remember the parts of the ureter, yung pinakadulong part, ureterovesical junction, the narrowest portion of your bladder. Ito po yun. Posteriorly and attaches to the bladder. At this portion, okay, yung ridge na yan, we call that the trigone. Okay? At the tip of the trigone, para yung letter Y ang shape. Okay? Yung isang hole would be the right ureteral orifice. Dito naman, this would be your left ureteral orifice. Alright? So look at the anatomy of how your ureter inserts to the bladder. It's a perfect angle. All the way down to the bladder neck. Diba? Our bodies are designed in such a way, if you notice, kahit hindi naman puno ang pantog nyo, nakakaihi kayo. Diba? Kahit walang valsalva, kahit hindi kayo mag-exert, just relax, you'll be able to urinate. Because of this, how your ureters are actually in line with the trigone to facilitate parang freely flowing of urine. So, para siyang funnel shape talaga. Okay? Yun yung flow ng urine natin in the bladder. Okay, a term for histology, the common question for this, other than the type of the layers or yung type of lining ng epithelium ng bladder, the most common question is actually the muscle layers. Strictly speaking, okay, if you are to ask, theoretically, the innermost would be an inner longitudinal, then a middle circular, and then outer longitudinal muscle layer. But okay, these layers are not distinct. If you would remember, what we accomplish with the bladder is for it to be stretchable. Okay, hindi siya strict. It's actually more of interlacing or mas buhol-buhol na layers of the muscle rather than it being actual distinct layers. Okay, so just for the layers, of course, you have your mucosa. It's composed of the epithelium and your lamina propria, followed by your submucosa, the muscle layer, and most lastly, your adventitia. So just some of the clinical correlates. For example, in the bladder, the types of cancers that could arise would be, for example, urothelial carcinoma, because it follows that the urothelium can turn into cancer. Now, for example, you have a bladder stone, chronic yun. This urothelium now becomes chronically irritated.
it becomes metaplastic to become squamous, di ba? Pag subject to abrasion, usually nagiging squamous yung layers ng epithelium natin, di ba? So, kaya ang bladder nagkakaroon din ng squamous cell carcinoma. And lastly, although uncommon, the bladder can also have adenocarcinoma. But then you ask, Dok, wala namang glands ang histological layers ng bladder. How come meron siyang cancer related to an adeno that pertains to a gland? Actually, adenocarcinoma of the bladder originates from here, your urachus or your median umbilical ligament. When you hear adeno, diba, it's commonly implicated with GI tract, diba? Kasi doon may glands talaga. But for this case, if you would remember again, the urachus is the communication between your allantois and your cloaca, which is somewhat part of your GI tract also. Hence the subtype histology of adenocarcinoma. Alright? So moving forward. Of course, you also have to differentiate the male and the female urinary bladder. May pagkakaiba pa sila. The bladder itself, wala. It's more of their relationship with other pelvic organs. Most particularly for the female, of course, it is intimately related with your uterus. Your uterus is said to be anteverted or naka-fold siya over the bladder. Okay? Whereas sa male naman, the most striking difference with the presence of your prostate. Its location would tell you na most of the prostate problems would give you voiding symptoms, diba? If this enlarges, the flow of urine can be obstructed. Now, what are the commonalities naman from this space? Anteriorly, actually all around the bladder, it is surrounded by your fat. But anteriorly, tinatawag natin yan na rettious space. That's spelled as RETZIUS. Okay? So, yun lang ibig sabihin, yun lang yung space or potential space filled with fat right in front of your bladder and behind your pubic symphysis. Sa male, sabi ko nga, not much difference, pero pag female, eto na siya. Your uterus is now here. I particularly chose this picture because I want to illustrate that the bladder is actually a pelvic organ. It's not intra-abdominal, it's pelvic. Because if you would trace the peritoneum, ang peritoneum mo would be around this line. Meron niyang peritoneal lining. In the female, ganun din. Meron niyang peritoneal lining above here. Okay? So what are its implications? Sa female, we have two potential spaces or dependent areas kung saan pwede mag-collect ang fluid. We call that as the recto-uterine pouch and the vesico-uterine pouch. So the vesico-uterine pouch is located here, behind the bladder and in front of your uterus, and it follows naman your recto-uterine pouch would be in front of the rectum and right behind of your uterus. But nonetheless, okay, other than those recesses, pareho sila, the peritoneum lines above it. So, for you to remember that relationship, I'd like you to give this clinical correlate. This is a bladder. Okay? The right side, ito, ang tinatawag natin na butas na bladder, but the perforation is extravesical. Ibig sabihin, although may butas ang bladder natin, the white part or the contrast will only be contained around your bladder because the peritoneum is lining here. Okay? So, ibig sabihin, yung contrast natin kahit sumabog or may butas yung bladder, probably the perforation of the bladder is here, or here, or here. Therefore, pag tumatapon yung contrast, hindi siya aangat or hindi siya mapupunda to the abdominal cavity. But, what's the difference with the other picture here? This is your bladder, di ba? Sabi natin, mayroong lining yan of the peritoneum here. Okay? Part of the bladder is intimately related to the peritoneum, lalo na in this area, which we call the dome. If the perforation or yung butas nangyari on this area, and the perforation spans the length or the thickness of your urinary bladder and involves the peritoneum as well, when you insert the contrast will now seep into the abdominal space. Kaya yung contrast, pansinin nyo, napunta in between your bowels. So strictly speaking again, the urinary bladder is a pelvic organ. But the dome is intimately related with your peritoneum. That's why perforation on those areas can lead to extravasation of urine into the abdominal space. More clinical correlate. This could be an emergency OR. Okay? This is not. For this case, insert na lang namin a Foley catheter, and if the hole is small enough, it will just heal on its own. But dito, since there's spillage intra-abdominally, we might have to repair that to prevent urine to seep into the small intestines. So that ends our discussion for the urinary bladder.
So that's the end of this part of lecture. We were able to talk about the kidneys, the ureter, the bladder, and partly discuss some of the adrenal anatomy as well. So if you have any questions, please do let us know, and I'll try to get back to you as soon as we
Good day,
can.
doctors.
Thank
Once
you.
again, I'm Dr. Kurt Roland Alfonso Asperas. I was again lecturing for anatomy and histology. This time, my topic is about the male reproductive system. Let's begin with the most obvious difference of the female and male urogenital triangle. Of course, the phallic symbol of your penis. Your penis is an erectile organ composed of 3 vascular erectile tissues. Okay? Your corpora cavernosa and then your corpora spongiosum. Bakit 3? Because the corpora is a pair. Dalawa sila. So how do you remember that? Para kang may letter C magkaharap. Okay? Sila yung corpora cavernosa. And midline would be your corpora spongiosum, S standing for single or solitary. And these structures collectively are being contained inside what we call the tunica albuginea. Okay? Also, using the same diagram, I'd like you to point out that it is the corpora spongiosum that is in close relationship with your urethra or daanan ng ihi and your ejaculate. Moving forward, we can divide the penis into 3 parts. The first part being the root, or this part. Okay? The root, it is composed of the 3 erectile tissues, the bulb of the penis, and the right and left crura. Okay? The right and left crura corresponds to your corpora cavernosa, whereas the bulb now is formed by your corpora spongiosum, and it terminates to the glans penis. The glans penis, or what we call the head of the penis, is formed by the terminal part of your corpora spongiosum. So, continuous structure yan. And it is covered by a fold of skin called the prepuce. Okay? May balat. This prepuce, ito yung tinatanggal natin during tuli. That's why we tell, ang diagnosis minsan dapat dyan ay redundant prepuce kapag circumcision is very much indicated. And it's on ventral side, we have a median structure, what we call as the frenulum. Prominent margin is the corona with small prepucial glands, or basically sebaceous glands, located on the neck of the glans penis, in their surface of which produces smegma, or sorry for the Tagalog, but kupal. So on the underside of your glans penis, may mga sebaceous structures talaga dyan producing your smegma. That's why the removal of a redundant prepuce would expose that area for better hygiene practices. The penis is there for 2 purposes. Other than urination, it is for reproduction. And for it to achieve its purpose, okay, penis is basically a conduit to harbor or to bring the male gametes to the vaginal tract or to the cervix or to the fertilization area of the female system. So for us to perform that function, ejaculation and erection has to happen. So erection before ejaculation, okay? Erection depends on the stimulation of the parasympathetic fibers from the pelvic splanchnic nerves. With stimulation, what would happen would be the arteries would now become dilated to supply the erectile tissue causing engorgement or kumbaga mapupuno yung ating mga tangke, which are your corpora cavernosa and your corpus spongiosum. So, lalaki sila maging filled with blood. Imagine a sponge being soaked in water. Ganun yung nangyayari sa kanya. And the main contained contraction of the bulbus spongiosus and ischocavernosus muscle on the pelvic floor will sort of impede the drainage of this blood back to systemic circulation. Kumbaga nagkakaroon ng traffic ng blood from its normal flow na dapat ma-drain, nagsistay sila longer than expected in the spongy tissues of your spongiosum and your cavernosa. On the other side of things, what happens with ejaculation? With ejaculation, it is stimulated by the sympathetic fibers, wherein there would be contraction of the smooth muscles of everything. The epididymis, the vas deferens, the seminal vesicles, the prostate gland, lahat yan sabay-sabay magko-contract to begin an erect kumbaga parang projectile na paglabas ng semen. But this projection is actually rhythmic more than it being continuous. There would be rhythmic contraction of the bulbus spongiosum, compressing the urethra, leading to the final end product of ejaculation. So how do you remember which is which? My mnemonic for that is point and shoot. Para kang bumabarel naman talaga. The pointing part when you are to shoot the gun, P standing for parasympathetic. Ibig sabihin, parasympathetic stimulation would cause the penis to point or erect. And when it's time to ejaculate, you will shoot now. And it's being triggered by the sympathetic nerves. Okay, so point and shoot, parasympathetic to sympathetic will fire the loaded gun. Okay, so now we're done with the penis. Let's move on to the scrotum. The scrotum is basically an outpouching of the abdominal wall of the male fetus. Kumbaga, pababa siya ng pababa. It contains the testes, epididymis, and lower ends of the spermatic cord. So embryologically, as the testis descends from its intra-abdominal position, bababa siya ng bababa, invaginating the abdominal wall, leading to the formation of the extra-abdominal cavity we call as the scrotum. This function is very important because very picky ang testes in terms of temperature. Actually, it's not the testis pala. It's more of the production of the sperm is very heat sensitive. So the scrotum, as mentioned, is just an outpouching of the abdominal wall layers to contain your testes and the other structures. Using this diagram, what I'd like to point out are the embryologic counterparts of abdominal structures to scrotal structures. For example, the peritoneum is the same or continuous all throughout. Okay? And supposedly, the peritoneum should end or obliterate here. Indented lang. But there are pathological states kapag yung peritoneum tumuloy-tuloy bumaba dito and mag-remain open. We refer to that as a hernia. Okay? Yun yung clinical implication of that. The external oblique muscle would correspond to the external spermatic fascia in the testes, and then so on and so forth. Transversalis fascia would now correspond to your internal spermatic fascia. So the point here being, almost all of your abdominal wall layers would have its counterpart in the scrotum. So basically, it's the abdominal layers na tinulak lang pababa as the testis descends to its final position. For the male genital organs, we're done with testis, the scrotum, and now we move forward to the other vital structures. Well, yung mga structures ito, walang pwedeng i-spare dyan. They play their important role to enable the male genital organ to perform its function. So roughly, we're done with penis, we're done with the testes. The epididymis acts as the collection basin or kumbaga maturation site of your sperm. So at this point, dyan nakukuha ng sperm ang capacity nila to be mobile, to be hypermetabolic, to have the capacity to actually fertilize an ovum. Once they reach those certain characteristics, it will be now harbored or dadaan sila sa highway that we call the ductus deferens or your vas deferens. This vas deferens, as it goes up, would meet the opening of other vital structures, such as that of your seminal vesicle, to provide nutrition, to provide more nutrients, and to provide other substances to further capacitate the sperm for fertilization. Okay? Those two would converge to your ejaculatory duct. Yung ejaculatory duct, dyan yung nag-differentiate kung ano yung dadaan sa penis ng lalaki. Kung ihi ba na coming from the bladder, or will it be sperm coming from the testis, epididymis, vas deferens, combined with the seminal vesicle, finally to your ejaculatory duct. Okay? And here, I'd also like you to notice the bulbourethral gland. The position of the bulbourethral gland is here. Okay? Right before the prostate and right before the urethra or the penile part of the urethra. It is said that the bulbourethral gland produces a basic fluid. Basic. Okay? Or kumbaga yung pH niya mataas. The purpose of which is to neutralize the urethra na might contain acidic urine. So kumbaga siya muna yung magpe-prepare ng highway para kapag dadaan na yung sperm, the highway is more or less ready or be more favorable environment for the sperm. More specifics about the testis. It is a firm, mobile organ lying within the scrotum. The left is usually lower than the right. Parang kidney lang, mas mababa si right as si left. The testis is being surrounded by three fibrous capsules, namely the tunica vaginalis, the tunica albuginea, and tunica vasculosa. Amongst the three, tunica vaginalis is found more exteriorly, or siya yung pinakalabas. The intermediate would be albuginea, and the most closely related to the actual testis, tunica vasculosa. So more about the testis, about its embryologic origin. As mentioned, early in the pregnancy, the testis is formed inside the abdomen of the fetus. And its descent is being facilitated by a structure we call the gubernaculum testis. It's a fetal retroperitoneal mesenchymal cord that extends at the caudal pole of the fetal testis and scrotum, and it guides the testis in its descent. It starts at 7th week age of gestation with the appearance of the gubernaculum. At the 10th week of gestation, the testis finishes its transabdominal descent. Transabdominal lang, meaning from a higher position all the way down to the lower abdomen. At this point, the gubernaculum now swells in preparation for the final descent of the testis that happens from the 20 to 28th week of gestation, wherein a transinguinal passage of the testis happens. So yung actual pagbaba niya from the abdomen down to the adult position of the scrotum is at the 20 to 28th week. The descent from a higher position in the abdomen to a lower position in the abdomen happens at the 10th week. So magkaiba po. Two parts ang descent, may intra-abdominal and mayroong trans-abdominal. What is its clinical implication? We refer to it as cryptorchidism, or simply in layman's terms, undescended testes. Having the knowledge of the embryologic origin of the testes, you can now explain why when there is a missing testis or walang palpable testis in the scrotum of a newborn, alam natin where to look for it. Okay? So the testis could still be intra-abdominal, pwede namang inguinal or suprascrotal ang ating position. Because, di ba, yung descent nga niya from a higher abdominal place, bababa ng bababa, and then eventually magka-transinguinal to the final position inside the scrotum. For those na mga magpipedya, make sure you include examination of the scrotum on the newborn checkup para ma-document natin kung dalawa ba yung eggs nung bata. After the testes, we will now be discussing the epididymis. It is found posterior. This is the testis. This is the anterior part. It is found posterior to the testis with the vas deferens lying on its medial side. It's a coiled tube. Okay, sabi nila, if you are to stretch the epididymis, it could be as much as 6 meters long. That's quite long. And it's composed of a head, a body, and a tail. The purpose of the epididymis is, of course, to collect the sperm that is being produced by the testes. The testis is composed by a lot of seminiferous tubules, okay? Coiled yan, eventually draining into the head of the epididymis, where there is sperm storage and maturation. The blood supply of your epididymis is your testicular artery and the drainage is veins, and it will drain to your lumbar vessels. The pathway for the sperm during ejaculation, of course, the production would happen from the seminiferous tubules to be capacitated inside the epididymis, would travel along the vas deferens to its final exit point to the urethra via the ejaculatory duct. And then it will pass down the entire length of the urethra, particularly of the penile urethra, to be expelled outside of the body and hopefully to the female genital tract to facilitate fertilization. Our next structure would be the vas deferens, which is basically a thick-walled muscular tube, approximately 18 inches long, spanning from the epididymis all the way up to the ejaculatory duct. The importance here in anatomy is that the vas deferens it courses through the inguinal canal. So it can be damaged when we do our herniorrhaphies. That's why it's important that you know that it's inside what we call the spermatic cord. It also crosses the ureter to reach the posterior aspect of the bladder. That's why when we do cystectomies, usually tinatransect natin yan. Or if you want to do fertility preserving procedures, kailangan alam natin as we mobilize the bladder and the ureters, pwedeng tamaan ng spermatic cord. It is at the ejaculatory duct, your vas deferens will be joined by the seminal vesicle, and silang dalawa yung magde-drain again as mentioned to the ejaculatory duct. In the previous slide, I have talked about hernia, okay, in the context of your vas deferens. But grossly, the vas deferens, in the context of hernia, it will be contained inside the structure what we call the spermatic cord. So inside the spermatic cord, nandun yung vas deferens, testicular vessels, and your spermatic fascia. If you would remember assisting in a hernia case, ito yung part or yung cord na nilalagyan ng Penrose drain or nilalagyan natin ng Army Navy. Then ino-open natin siya, hopefully identifying the sac of the hernia, and at the same time we'd also like to be oriented of where the vas deferens would be because we don't want to ligate that to preserve the fertility of our patient. The ejaculatory duct is simply the union of the ampulla of the vas deferens and the seminal vesicle. Kumbaga, dyan sila magmi-meet here, okay, yung common space nila para ma-expel siya to the urethra. Diba? Unlike females na iba ang daanan ng ihi sa daanan ng female genital organ, sa male pareho lang yan. And ang nagiging point of convergence nila would be at the ejaculatory duct. The ejaculatory duct, just a few generalization. The epididymis is for sperm maturation. The vas deferens is just a carrier or a tube or highway for the sperm, and the ejaculatory duct's purpose is to deliver the sperm to the urethra. The seminal vesicles are two lobulated organs lying on the posterior aspect of the bladder, about 2 inches or 5 centimeters long. Medially, the vas deferens can be found. Posteriorly, nandun ang rectum, and inferiorly, it is together with the vas deferens and the ejaculatory duct. Its secretions includes fluid, fructose, ascorbic acid, amino acid, prostaglandins. So what do you notice with its secretions? These are components that actually for support or for nutrition of the sperm, di ba? Kasi mahaba-haba pa yung ita-travel ng sperm natin for fertilization to occur. If you would see again its location, ito yung bladder yan, and we're looking at it from behind. Paano ko nasabing from behind? Kasi kita natin si seminal vesicle. And in this sample, kita rin dito si prostate. So why is this picture very important for us, or bakit very well versed ang mga urologists dito? Because when we do our prostatectomy, okay, sinasama namin yan. Okay, kinukuha natin ang seminal vesicle and part of your vas deferens to the specimen. Okay, so magkakatabi talaga sila. So moving forward with the last gland for this lecture would be the prostate gland. So the prostate gland can be divided in so many ways. In terms of lobes, meron tayong anterior and posterior. Anterior and posterior to what? The urethra. Okay, if this is the urethra, everything found anterior to it is called the anterior lobe, and posterior to the urethra is the posterior lobe. Now, left and right, pwede mo ring i-divide ang prostate, and we refer to that as the lateral lobes. Lateral, where again? From the urethra. And we also called what we call the middle lobe, which is a wedge-shaped part of the prostate found superiorly or in close relationship to your bladder neck. So, nasaan yun in the diaphragm? Ang nakita lang nandito natin sa picture would be the anterior and the posterior. Yung left and right could not be seen from this cut, pero dito ma-appreciate natin yung middle lobe. The middle lobe is the wedge-shaped part in close relationship to your bladder neck here. Okay? So, how is the prostate related to other nearby structures? The prostate superiorly is in close relationship with the bladder neck, or doon sa funnel site or labasan ng ihi from the bladder neck. Inferiorly naman, it is found at the upper surface of the urogenital diaphragm. So, anteriorly, if this is the pubic symphysis, we have a layer of fat here that we refer to as the retrospace that separates the prostate gland from the pubic symphysis. Posteriorly naman, we know that the rectum lies posterior to the prostate. Kaya nga kaba ang prostate via the DRE. But anatomically, there is a distinct space in between those two structures, separated by the Denon-Villiers fascia. More than the previously mentioned divisions of the prostate, from a urological standpoint, pwede mo ring i-divide ang prostate gland into a peripheral, a transition, a central, and anterior fibromuscular stroma based on its location and content. The peripheral zone here in purple is the largest and can be easily felt during DRE. As it across all definitions, siya lagi yung pinakalabas and nasa close relationship with the rectum. This is particularly important again because this is the most common site of malignancy. A transition part is the part that surrounds part of the urethra, and it is the part that actually enlarges as a person gets older. Look at its relationship. If this is the bladder neck, this is the transition zone. If this zone enlarges or nagugunta siya intraluminally or lumalaki siya paloob, it could be bad enough to cause obstruction with the flow of urine. Whereas the central naman position lies behind the transition zone and it surrounds the ejaculatory duct. Ito naman si central zone. Whereas the anterior fibromuscular stoma is the thickened area that surrounds the apex. Okay? So what is the clinical implication? Why for urologists or for other doctors, the zone of the prostate makes more sense? It will be in the context of benign prostatic enlargement. Because in what happens with BPE, this is a normal prostate. This is your prostate, the right and the left prostate. Once the bladder contracts, dapat the urine would flow freely through the bladder neck all the way down to the urethra. But with prostate adenocarcinoma or BPH, what would happen there is there are parts of the prostate that would enlarge, particularly the zones belonging to the transition zone or those areas that are in close proximity with the urethra. If ang growth niya would be inwards, it would result to impedance of the flow of urine. Okay? Likewise, in the same manner, lagi nating sinasabi, not because malaki ang prostate would automatically mean that the patient would be symptomatic with LUTS or lower urinary tract symptoms. If the enlargement would happen on the lobes of the prostate that are not in the transitional area, okay, we are not to expect obstruction because those areas naman ay hindi related or hindi nakakadagan sa ating urethra. So, yun lang yung small implication of the zoning of the prostate. Kailangan yung zones na lumaki are the zones close to the urethra to cause symptoms. Otherwise, the patient will still be voiding freely kahit 80 grams or 100 grams yung prostate niya. So with those points, I'd like to end my lecture. Should you have any questions, please feel free to contact me through Doc Broly or other faculty of the anatomy lectures. Thank you.